Assalamu alaikum. Bismillah ar-Rahman ar-Rahim. Hello. My name is Adel Shabana. I'm assistant professor of cardiology, October 6 University. And today we will talk about heart examination for skill lab. This is supposed to be for fourth year for the module of cardiovascular system in the fourth undergraduate year. The first lecture is about inspection and palpation for the heart. Inspection and palpation, the first thing we need to know what are the areas we are supposed to inspect and palpate. So in cardiology we have four important areas which we have to know. The first area, which is the most important one, is the apex of the heart, or we call it the left ventricular area. This one is supposed to be typically it's supposed to be in the left fifth intercostal space in the mid clavicular line, and we call this LV area or apex beat. The second area is the RV or the right ventricular area. This is in the left parasternal border in the spaces 3, 4 and 5. So it is the third, fourth and fifth intercostal spaces just at the left sternal border, parasternal or just near the sternum on the left side. Then we have two other important areas. We have the pulmonary area, which is in the second left intercostal space, parasternal, and we have the aortic area, which is in the second right intercostal space. Okay. Sometimes we also may need to inspect and palpate in the epigastrium, so for the right ventricle also. So sometimes this area is added to the cardiac areas. So basically we have four areas: left ventricular area, apex beat, right ventricular area, pulmonary area, and aortic area. I know that this may appear like it is very busy slide, but let's talk about what are the steps we need to do if we are asked to inspect and palpate the heart, and then we will talk about them one by one. Of course, if you have a patient, you have to greet the patient, introduce yourself, stand on the right side of the patient, take permission for examination, warming hands, and uncover the patient. And then the first thing is inspection. In cardiology, usually we do inspection and we confirm by palpation if needed. We don't do separately inspection and finish all the aspects, then palpation and finish its aspects. So first we have to inspect the skin itself, as you may have taken in the chest pulmonology, like look for scars, look for hair distribution, look for prominent veins, movement of the chest, and of course pulsations. Pulsations are important for the heart. So we inspect the chest for any pulsation. In most people, usually the apex can be seen pulsating, and we call this apical impulse or the point of maximum intensity, PMI. Okay, so in most people, especially if thin people, we have to find, usually we can find or we can locate the apex by looking at the beat itself of the apex. Sometimes we have other pulsations in the other areas, and if we inspect any pulsation, we have to palpate this pulsation in order to know what is the character of this pulsation. We will talk about this in the next, in the following slides. Okay, so the first step, we have to inspect for the usual things like scars and hair distribution, and important also is the pulsation, especially the apex. And then we will spend a lot of time for this apex, because we have to inspect the pulsation of the apex. We have to confirm by palpation that this is really the apex beat. Actually, by definition, the apex apex beat is the outermost, lowermost visible and palpable pulsation. So we have to find the pulsation by looking, and then we confirm by our finger, and by some fine movement of our fingers we have to locate the lowermost outermost pulsation. Okay, and then we will count by our fingers and to see what space we are in. And please don't do the common mistake, which is when we ask some people to locate the apex, they first count the spaces and then reach the fifth space and try to find the apex. This is not right. You have to do the opposite. You use your right hand, try to find where is the apex, and then when you locate the apex by one of your fingers, you use your left hand to count. You have to see us. We will also attach a video showing how to do this. So you have to count by your left hand in order to see where is the apex now, where is your finger. Okay. And we locate it horizontally through the spaces and vertically in which line, mid-clavicular, anterior axillary, or other lines. Okay, so what about if we could not see pulsation, and even when we palpated the area we could not feel any pulsation? Sometimes this happen. You are asked to locate the apex. You look with your eyes, you don't see any pulsations, and then you try by your hand to locate the apex, you don't see any pulsation, you don't feel any pulsation. So there is a terminology called impalpable apex or absent apex beat. But in order to say that, first you have to put the patient in the left lateral position. Why? Because when we put the patient in the left lateral position, you make the heart near to the chest wall. So maybe you can see the apex beat or feel it. So if you put the patient in the left lateral position and you try to locate the apex again, you may find it by your fingers. If this happens, then you keep your finger in this space and return the patient back to prone, and you try to locate where is your position. Okay, if you did not feel or see any pulsations while the patient is in the left lateral position, then you can say that the apex beat is not felt. Okay, we will talk about the causes of that. Anyway, after if you find the apex beat, whether you are in the left lateral position or from the beginning you can locate it, you have to comment on several aspects. The area of the apex beat, is it localized, occupying only one space, or it is diffuse, means it is present in the pulsations is in more than one space. The character, we have different characters of the apex. The normal one is that we call it tapping, like it can hit your finger and make some brisk outward movement of your finger. And then the duration also of the apex beat, is it filling all the systole or it is extending till the diastole? And in order to do that, we have to compare with the carotid. And finally, if you are allowed to auscultate the apex, you can also check if it is it's occupying all the systole, or it's only a short wave. Then after you finish the apex, you have to look for what is called the thrill. We will talk now about all this. So after we finish the apex, we have to check for thrill, and we can also check for heave. Then you go to the left parasternal area to check for the three things: pulsations, thrill, and heave. And then you go to the pulmonary and the aortic areas for thrill and pulsations, no heave upward. And then sometimes we go to epigastric, and sometimes there is no need for that. So let's talk about the details of this. First, by inspection, it's very important to check for scars, because this is very important in cardiac patients. So the main scar we want to look for is this one. This scar is called median sternotomy scar. And this scar, when we find it, this means that this patient mostly underwent cardiac surgery, open heart surgery, whether it is for valve replacement or maybe for coronary artery bypass. Okay. Of course, sometimes this stenotomy is due to other things, but for cardiac patients, usually it is valve replacement or coronary artery bypass. Usually it's valve replacement. The second one is a scar which is under the breast, so we call it inframammary. So some people call it sub scapular. Sorry, it's called inframammary scar, left inframammary scar, and this is, in the past it was commonly done to dilate mitral stenosis. It's called open valvotomy scar. Now it's rarely done. Another scar you may find around the clavicle, which is maybe due to a pacemaker device insertion called the pacemaker. So sometimes there is a scar up here and you will find some small bulge near it because of this pacemaker. Okay, we said that when we palpate the heart, we have three things to palpate: heave, thrill, and pulsation. So let's talk about this first. What is heave? It's also called lift. Heave or lift means there is a big chamber which is contracting under my hand. So it should be diffuse and a big, it's like a ball hitting your hand from down, from the patient's chest. So it is not a small one, it's not a pulsation. It's a big, strong, like a fist hitting you or a ball hitting you. And in order to appreciate it, you usually use the palm, your palm, like here in the figure. So this area, you put this area in order to appreciate the heave or lift. Commonly, the heave or lift will be a big chamber like right ventricle or left ventricle. So we have to palpate it at least in the right ventricular area. Sometimes we can palpate in the left ventricular area also for LV, but the more important is to palpate it in the right ventricular area for the right ventricle. The second thing is a thrill. The thrill is a vibration. It is a palpable murmur. So when turbulence occurs, turbulent flow occur like in valve stenosis or valve regurg or ventricular septal defects. If this turbulence is very strong, it can be felt, not only heard by the stethoscope, but it can be also felt. And we call this thrill. This thrill looks like if you put your hand on the back of a cat, there is some thrilling sensation, or at least you can make your mobile on vibration, and you put your hand on it and you feel this vibration, and it indicates that there is some murmur in this area. You can feel a thrill on any of the areas we talked about. In the area for you can feel the thrill for aortic valve, for mitral valve, for tricuspid valve, even for ventricular septal defect. All these can produce different thrills in different areas of the precordium, and we can feel the thrill with the base of the fingers. Okay, so this is the area which you need to put it on the area of the heart to feel the thrill. The third thing which we are talking about is the pulsation, same like the apex beat. Pulsation is a localized feeling, a localized movement, which can be appreciated by fingers. So it needs to be done by the tips of the fingers. They are usually palpable heart sounds. So thrills are palpable murmurs, but pulsations are palpable heart sounds. So the most common one is the apex beat. This is a pulsation from the first heart sound. First heart sound is the closure of mitral valve, followed usually accompanied by the apex beat itself. This is one of the pulsations. Sometimes second heart sound, if it is very high, this is a closure of pulmonary and aortic valves, so it will be felt or palpated on the aortic and pulmonary areas. Sometimes we can feel also third heart sound and fourth heart sound, whether with the LV or on the RV area. Again, let's revise what we said about the apex beat. So the apex beat is the it 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 is due to the left ventricle when it hits the wall at the start of its contraction. So we inspect for it first and then confirm by palpation. When we find it, we try to make some fine movement until we find a space which is the lowermost outermost. And then we use the left hand and try to count the space, starting from the second space, because the angle of Lewy or the sternal angle is just opposite to the second intercostal space, and then we go by our left hand to try to find second, third, fourth, fifth until we see where is the apex beat exactly. And as I said, if the apex beat is not heard, is not seen or felt, then you put the patient on the left side and try to detect the apex. If you can find it, you keep your finger and return the patient back to supine again, and then try to find the count the spaces. If you cannot locate it in the left lateral position, then the apex is not felt. Why the apex cannot be felt? Actually, the most common, what's common is common, because we notice that when we ask this question, why the apex beat is not felt, the first answer will be dextrocardia. Okay, dextrocardia is one of the causes. First, it is not very common, and second, if dextrocardia, I will tell you, okay, you think it's dextrocardia, then please check the apex on the right side. So this is not a common issue. But what is common is common. Why we cannot palpate the apex beat? Very easy. Maybe obesity, maybe some abnormality in the chest wall, maybe the apex beat itself is under a rib, so it cannot be felt by fingers. Maybe the patient is having a pleural effusion, precardial effusion, even patients of COPD or pneumothorax sometimes. All these are causes why we cannot find the apex beat. But before we talk about this, we have to put the patient on the left side and try to see if we can palpate the apex beat or not. And then, as I said, when we palpate the apex beat, we have to comment on four things. The area, meaning that it is localized or diffuse. Normally it is localized, meaning that it is only in one space. Character, normal character is tapping, as I said in the beginning. And then duration, comparing it with the carotid, we can see that if it is, I can feel the apex beat quickly before the carotid. Sorry, it comes with, I mean, like the apex beat, you will feel it with the carotid and then it ends quickly. It does not extend until the carotid pulse is finished. Or when we auscultate the apex, if we are allowed to auscultate, we can also see if it is coming with S1 and first heart sound and continuing to the second heart sound, or only very short. Normally, the normal apex beat should be by location 4/5 intercostal space mid-clavicular line. In diameter, it should be localized, meaning that it is only in one space. Amplitude or character, it is brisk and tapping. It is not prolonged and it is not very strong or very weak. And the duration usually almost up to 2/3 of the systole only. We will talk later on about what are the different abnormalities which we can find in the apex beat. Okay, after we finish the apex beat, now you finished only the apex beat as a pulsation. So this area we need also to check for thrill. So you have to put the base of the finger on the same area and see if you are feeling any thrills or not. Then you go to the left parasternal area, which is the RV area. You have to check for three things: heave, thrill, pulsation. So you have to put in the same area, you have to make three movements. You have to put first your palm to feel heave, then you put the base of the fingers to feel the thrill, then the tips of the fingers to feel the any pulsations. Then you go up to the pulmonary and the aortic areas. There is no thrill, no heave up, so you can In each of these areas, you can check for thrill and pulsation. Here, this one is looking for pulsations. Okay, so the tips of the fingers are in the pulmonary areas trying to feel any pulsation. In this figure, the doctor is putting the base of the fingers in the area. So he is looking for thrill. So first you can put your finger like this to look for thrill, and then like this to look for pulsation or whatever sequence you want to do. Thank you. I hope the lecture was clear, and we will continue later on other lectures. We'll try to find some videos to show you how to do. And in the practical part, when you come in the skill lab, we will show you also how to do that. Most of the abnormalities you will take in the lectures and in the clinical sessions. Thank you.